Okay, so hello everybody, welcome back once again for my first sort of post-finals interview, which is a nice juncture to be on the other side of finally, but good to get back into speaking to lots of very exciting people, the first of which is going to be the inimitable Dr. Jonathan Guckian. Thank you for joining me today.
That's great. I've been called much worse than that.
I bet. Well, Jonny is a
Thanks.
dermatology registrar, and they are much harder to get hold of than you would think. They're a very sought after bunch, even in terms of doctors, hard to pin down and get hold of. So really, really thankful that Jonny's able to come and speak to us today.
It's all right. It's quite hard to spot a lot of the time because light kind of passes through us, because our skin is so clear and translucent, so you can't actually
So
see
well
us.
looked after. So essentially the theme of this interview today is going to be dermatology as a career, or I suppose career insights into dermatology, because it's one of the specialties that I think, and obviously feel free to pick me up on this, Jonny, but it doesn't fall into the same circles as most other medical specialties. It seems to exist kind of in a space on its own. So maybe it might be best just to start with a brief run through your journey through medical school and how you got to where you are now, and then we can jump into dermatology proper.
Yeah, sounds great.
Cool.
So my story through medical school is one of banal mediocrity. And so I basically didn't really know what I wanted to do until about third year, which actually, to be honest, I now consider to be quite early in terms of deciding what you want to do.
Yeah.
I went to a dermatology clinic as an extra thing, which is the first time I'd done that. And my consultant, Dr. Meggett, told me that I'm going to have you wanting to do dermatology by the end of this clinic. And he wasn't wrong. So that was quite nice. And I thought, I know we said we'll talk about dermatology later, but it kind of starts the story here. And
Sure.
I think with dermatology for medical students is that you can kind of be let loose, and how much harm really can you do in a dermatology clinic. So I like that independence that I was given at the time, and I'm sure we can come back and talk about why I chose dermatology. Then so I had that in the back of my mind that I wanted to do it. So, and that's important because that kind of guided what I wanted to do throughout. But then I did the most important part of my medical school career, which was our medics review in fourth year, our comedy show, which remains the proudest thing, proudest moments of my life. I'm
Do
writing
you maybe
60
just
pages of
want
script.
to go through what a medic's review is? Because I feel
Oh
like
yeah.
it's common, but maybe
Um,
people won't have heard of it.
yeah, people who've never heard of it, it's a comedy show. Much of the review I did isn't online anymore, because times have somewhat evolved and changed since I did that too in 2012, which wasn't that long ago. Um, uh, and it's basically a sketch show about medic life. And I wrote like 60 pages of script for this, with some of my best mates, or people I didn't really know at the time and who are now my best mates. We brought that together on stage. I'd never done anything on stage before, and it was just so much fun. We did, a parody of Tribute by Tenacious D, and we did Mock the Week style stuff. Oh, it was great fun.
Yeah.
And I loved that, and I thought, oh, this is great. I like attention, as you may be able to tell for the rest of this interview. And then so I wanted to carry that through to my fourth year, and so I discovered at that point medical education, um, which is my other big passion. And that's why I ran our medical education society at Newcastle, which I know there's quite a few med ed societies about now, but the Newcastle one was one of the first. It was
Yeah.
really based in peer-led med ed. And so I ran that in our fourth year, and that really just helped me get into organizing things, logistics, a lot of spreadsheets, and doing just really getting to know a lot more new people. And I got to do that with a lot of my mates from my review, which is what really sparked that interest. Then I kind of retreated into finals haze, almost failed finals, but just about squeaked through. I was ninth decile and proud, and I proudly say that. You don't need to be first decile, you don't need to have honors. Med school, there was never a danger that happening to me. And then I went into foundation, didn't do AFP, just, I don't want to say just did foundation program. There's no just in
It
medicine,
sounds
really.
hard.
Yeah. And I was in, I should say, sorry, I was a Newcastle grad, and I did my foundation program in the Northeast. So I was in Bishop Auckland, Durham, Darlington,
Lovely.
bizarre move to Gateshead at one point for GP, and then did a couple of years as a teaching fellow. 1 year as a teaching fellow in elderly care in South Shields, and then a year as a teaching fellow in dermatology in the RVI. So that's really where I got my experience with that. And then I dove into what was then core medical training for 2 years, which was after going and being essentially acting up as a dermatology reg as a teaching fellow, and being trusted, listened to. People came to me for advice. I felt comfortable what I was doing. Diving back into core medical training as a stroke SHO was a little bit traumatizing. But then I started as a dermatology registrar just last year in September, and that's where I'm at now.
So you're very fresh, I suppose, into the dermatology role. I guess before then, well, no, I'm second guessing myself. I think maybe it's best if we tackle what a dermatologist actually is before we move on, because I feel as though to people who maybe aren't so familiar with dermatology and skincare and skin pathology, there will be a lot of confusion potentially around terms like aesthetic medicine and cosmetic experts. And what is the role of a dermatologist?
It's a good question, and it's an important one because you could spend an hour on Instagram and not know. So I when I was a teaching fellow, I did a talk with some dentistry students, and it was a big long talk. And at the end of it, I said, any questions? And every hand went up. And then I said, any questions which don't involve aesthetics? And every hand went down. So there is a big confusion between dermatology and aesthetic medicine, or cosmetology, or whatever you want to call it.
Yeah.
Dermatologist looks after the health of the skin. Okay, it's not necessarily about cosmetics, though obviously cosmetic appearance is a big part of your outcomes in dermatology, but it's not the be all and end all. It's about health of skin. So that means there's a huge variety of roles within dermatology. So dermatology is the biggest specialty in the world. There are more dermatology conditions than there are in every other specialty put together. Cool. So there's more than 3,000 dermatology conditions. Most of them are either abhorrently Latin or named after Nazis, but we're trying to fix that.
Right.
Yeah, basically it's generations of old bearded white guys who wanted to name things after themselves. Again, we're trying to fix that too. But what that means is that there's so much variety. A dermatologist might be interested in skin cancer, so do a lot of skin cancer clinics and surgery. So you do skin cancer surgery, and that can involve different types of surgery, including Mohs micrographic surgery, which is a bit of surgery. They cut a little bit, literally turn around, look under a microscope to see if they got all of it, turn back around again, cut a bit more out. It's really quite high level stuff. Or you might be involved in phototherapy. And do photodermatology. You might be involved in psychodermatology and look at the mental health aspect of dermatology. There's patch testing, looking for allergies. There is allergic dermatology, which is slightly different than patch testing. There is biologics, because there's a whole load of new fancy expensive medications. There's pediatric dermatology, so you can actually get into dermatology not through the route I did, which was medicine. You can get in through pediatrics. You can also now get in through surgery and ACCS, apparently.
Wow.
Which is very interesting. That'll be a bit of a role reversal, but each to their own. There are other areas which are more slightly aligned with the cosmetics. So acne, though acne isn't, I always say it's not just acne. I work in Harrogate, which is a kind of acne tertiary center. And though cosmetics is a big part of it, it's also a big aspect of mental health related to acne. And honestly, it's one of the most satisfying things to treat. So yeah, so much variety. Dermatologists will generally work in clinics in all of those areas, but then they also have acute dermatology, so ward dermatology related to medical dermatology, and then on calls. So I do on calls covering Leeds and um, other parts of Yorkshire, even though they're not really supposed to call us. And
I come for your
I
expertise, Jonny, clearly.
well, yeah. I mean, they're not just calling me. I should put that out there.
You're just holding the blame.
Yeah, yeah. Let's call him. He's a mug. We know he'll answer. No, and we deal with dermatology emergencies because they do exist. So a dermatologist really looks after the health of the skin, and we our priority is to make sure you don't die of a skin problem, and make sure you don't have a life-limiting skin problem or a big morbidity from a skin problem. And then the cosmetic stuff is kind of on top of that. Whereas cosmetology or aesthetic medicine puts the aesthetics first, and whilst that can be greatly valuable, that's more aligned to private medicine rather than NHS.
Yeah. So if we're thinking something, I mean, the obvious examples are things like lip fillers, Botox injections, things like that. Is it fair to say that some of the people who do those things will be dermatologists? But
some of them,
yeah,
so particularly Botox, and it's important to say we do Botox for other things like hyperhidrosis, so
yeah,
excess of sweating in the axilla. But yes, for your standard kind of cosmetic Botox or fillers, they're not really. I mean, most of those aren't done by dermatologists. Most of them are actually done by. I've seen a lot of people in emergency medicine do those, and also nurses. But yeah, a lot of dermatologists do private work as well.
I suppose maybe. I mean, my instinct would tell me that you're probably paying a premium if you want access to a private dermatologist to do your procedures. Is that fair?
Yeah, I guess it'd be region specific, but I would say that from my experience, private dermatologists are mainly existing as a kind of a second tier to standard dermatology healthcare. So if your waiting list in your area is very, very long and you want to get seen quicker, and that's not felt to be urgent by your GP, then you can get in and see a private dermatologist pretty rapidly, but it'll cost you.
Yeah, I guess as with all private care. Now, you did outline some of this when you were talking about your own pathway, but that was something that I got quite a few questions about, which is what is the typical training pathway for, say, I'm fresh into medical school, in my first or second or third year or whatever, and I start thinking that I might want to do dermatology. What's my pathway?
Okay. Your pathway generally is finish medical school, do your foundation program. You don't need to do AFP. And then technically it is go straight into either internal medicine, so IMT, or pediatrics, surgery, or ACCS, like I mentioned. Surgery is a new one for this year. And then complete the core training for those. And that's 2 years, I understand, for each of those. So with internal medicine training, if you're not doing a group 2 specialty, which is dermatology, allergy, genetics, rehab, things like that, you have to do 3 years normally, but with derm, you can do 2 years and exit at that point. You don't have to be in med reg, okay? Which is an important point. And then you get into dermatology. However, in reality, the vast majority of dermatologists, if you ask registrars, you will find that most have done a fellow year in dermatology, like I did. And it's a bit rubbish. It's like you need experience before you get experience. That age-old problem, and that shouldn't be the case. In my opinion, that's a sign that our training programs are failing us. If I was given all the money in the world and all the license to break things, I would probably create a dermatology run-through program. But I've had lots of debates with my colleagues about that. Yeah, and the other thing, so I should just clarify about med regging. So you don't have to do med regging. I did, but that was purely because at the end of your second year of core medical or internal medicine, or towards the end, you're generally judged to be relatively competent, and rota gaps pending, you're often asked to act up. Right. So I acted up for 6 months because we had a little pandemic thing going on.
So just a little one.
Just a little one, yeah. So rather than rather than doing my dermatology placement, which I had, I ended up doing 6 months pretty much of seeing the first COVID patients in the region slash, some of them were the first in the UK. So that was fun.
So just to again clarify for the boys and girls at home, so what Jonny's referring to is this divide between run through specialties and non-run through. So in a run through specialty, the way it works for the benefit of those of you at home is that after you finish your foundation training, which is those 2 years after you finish medical school, you can enter straight into usually an 8-year, 7 or 8 year training pathway for a small number of specialties that is growing slowly. And this bypasses the need to do a lot of these extra training competitive steps. For most specialties, as Jonny said, you would go into either what used to be called core, either medical or surgical training. You would do a couple of years of that, and only then would you then finally commit to a specialty. But this involves this step of being the med reg, or the surge reg even, but the med reg has this gravitas, this kind of fear associated with it. Maybe just talk for a minute or two about what that is.
I'll talk for a minute about med reg. So med regging it's got a lot of negativity associated with it, negative connotations. It really varies depending on where you are. I actually quite enjoyed my time being a med reg. I was quite terrified, but when I started it, but actually, I felt I was ready. I think that's because I'd taken 2 years out, and I felt I was ready to act up a little bit. I was ready to take more responsibility. I was sick of being the SHO in old money, and I wanted more responsibility. And it's different being a med reg. You have to think about delegating jobs and identifying who's the most important person for you to see. And I worked in a big tertiary center where really all of the respiratory, gastro, and cardio problems were sent elsewhere. So I really just dealt with diabetes, overdoses, and then a few random stuff. So it was quite nice for me.
Okay.
Whereas in district general hospitals, it can be a bit more challenging because you are the doctor, you are the person that everyone contacts, and that's why it's quite scary for people.
Yeah. So that's what even someone as junior and inexperienced as me, for example, who hasn't left med school yet, that is exactly what you hear. The med reg is the competent, reliable doctor that if you have a problem, they're the one that you need to go and find, because you either don't want to bother a consultant, or the consultant's doing something else or is at home, but the med reg is there and has to help you if you ask.
There's generally not enough med regs, and so it can be a very overwhelming task. But actually, I think it's getting better.
Sure. Now, I think that actually brings us quite nicely onto, so you talked about taking years out and being a fellow. Dermatology is, at least from what I hear, and I think the statistics would support this, it's one of the most popular specialties that doctors, I suppose, would like to go into. Do you have any thoughts on why that might be?
So the reason I think people want to do dermatology, aside from it just being the best specialty in the world, or the reason it's difficult, sorry, to get into dermatology, is because it's not just that there's a large number of people applying, it's that there's a lot of unique applications. So
Right.
people who want to do dermatology tend to just apply for dermatology in the most part. So that means you've got a lot of people who generally tend to be very, competitive in terms of their CV, applying for what is a ridiculously small number of training numbers.
Mm-hmm.
The other thing I learned recently was that if you are a current trainee, you can actually reapply. So I know, makes no sense. Me, well into my ST3 year, if I didn't like Leeds and let's say I wanted to apply for Edinburgh, I could reapply, I could re-interview, and I could be competing against any of you guys out there who are IMT2s, which
So
makes
if you
no
wanted to
sense
go to
whatsoever.
London or something, that
Yeah, if I want, exactly, yeah, that's exactly what happens. And actually, it's quite common because there are so few numbers. So I knew somebody previously who was commuting from Wales to Newcastle, and he had a child in Wales. I know someone who commutes from London to I think it's like around like Manchester.
Wow.
It's outrageous. And there needs to be more investment in training because there's a massive like gaps at a consultant level. But yeah, so that's why it's challenging, but it's not impossible. I do know people who've got through without taking fellow years. I do know people who've got through without the golden CV. A lot of it is really about interviewing and luck, as with any applications.
Wow. And then, I mean, to kind of come back to the central point, I mean, one of the things that I hear, although I feel like if I phrase this not particularly sensitively, I'll get slapped down. But is it fair to say that has perhaps a nicer lifestyle associated with it?
Yes and no. So yes, it's more from this is me talking from experience,
Yeah,
okay?
sure.
Genuinely from rather than from any preconceptions or anything like that. Yes, I don't do the horrendous on-call shifts that I did as a med reg. However, in Yorkshire, I currently have to do 24-hour on calls.
Oh,
So
wow.
I do on call, or I'm on call all night for dermatology. And you'd think, who calls dermatology in the night? Well, turns out a lot of people call dermatology in the night for nonsense. And that's really difficult because you don't know what's going to be nonsense, what's not going to be nonsense. And we're actually changing that, and we're not going to be on nights. But we've really had to fight for that ourselves as a registrar group. Um, and you know, specialties evolve, regions evolve, and education evolves. That's how these things go. Saying that, there are a lot of extra things you need to do in dermatology. So all of the extra things you do to get into dermatology doesn't really stop. Once you're in there, there's a big culture in dermatology where you have to create a lot of presentations. So journal clubs is a thing. Academic ward rounds, when I was in Newcastle, was a big thing. So bringing a patient in and presenting them, complex patients. Histopathology is a big thing. Suddenly you have to, you know, having done no histopathology before, you have to just encounter this entirely new specialty and be good at it. Same for surgery. I'm not a very surgical person at all. I didn't do any surgery. I prided myself in getting through my F1 surgery job without going to theatre once, which I thought was an achievement. And now suddenly I have to do a lot of surgery, which is, you know, makes me come out in cold sweats. But so there's a lot of extra stuff. You're expected to publish. You're expected to go to conferences. You're expected to go to courses, which are expensive. So whilst it's not obviously the horrendous hours that you would be expecting in perhaps some other training programs, it's still a big time burden, and it's not paid as well as some of the other registrar programs. So if you're doing 9 to 5 because of the new contract, you're paid 9 to 5. You're not paid for much extra. I don't really get paid much at all for my on calls.
I see. Okay. I mean, that's interesting because it's certainly something that I've heard, but clearly it doesn't sound necessarily that the reality.
Yeah, it kind of depends. You have to think about this. I'm talking about a training program perspective. Actually, you know, you shouldn't look at what trainees do as your model for what specialty you want to do, because actually you should look at your consultants, because you're really going to be spending, you know, 20, 30 years of your life as a consultant rather than a few years. 4 years for a dermatology program is nothing. So the consultants often do 2-3 days a week. In fact, that's why perhaps there's a lot of gaps in dermatology, because a lot of dermatologists and a lot of consultants across specialties don't do 5 days a week. And there's some private work which is quite lucrative, I hear, and then there's the cosmetic side of things, which some people do, and then as a dermatology consultant, again, depending where you are, there's not necessarily a lot of time burden for on calls. You can kind of roll over in bed, pick up the phone, and put the phone back down again. Yeah. So yes, I think that's where the lifestyle stuff comes from.
Okay. Something, again, you've kind of hinted at this already. It would be interesting to try and unpack it a little bit, but the idea of subspecialties and career options and things like that, I had quite a few questions about the perhaps different types of dermatologists that there are, or what you can do once you are a qualified dermatologist. Where do people go?
So it depends on your journey. It depends on where you are as to what's available. So some people come into it as very surgical people. So I know a lot of people who've done perhaps dentistry. I know people who have done some core surgical training before, and then done core medical, just to get into dermatology. And therefore, there are a lot of surgical dermatologists, and that's great. You know, we absolutely need them. They're fantastic, and they can do a load of special types of surgeries like grafts and flaps and Mohs surgery, as I mentioned earlier. Then there are the medical dermatologists. So I would probably count myself more as one of them based on my own experiences. So managing on-call patients, managing patients with things like lymphoma, or acute things that are bringing them to hospital, like connective tissue disease and vasculitis. The patients who are sick acutely. Then there are the kind of clinic subspecialties, which are big, but maybe not necessarily as well known. So there is skin cancer clinics, but within that you can get melanoma clinics. And because melanoma is huge, there's loads of new therapies with regards to it. So immunotherapy is massive in melanoma. And there are consultants in immunotherapy for melanoma, so that's a huge special subspecialty. There is hair dermatology. So I worked in a hair clinic in Pontefract, which was really interesting. Yeah. So and it really matters to patients. It's not just cosmetic, really. You get patients with scarring hair loss, which can massively impact their quality of life, especially in kids. And so I treat a lot of kids with alopecia, or different types of alopecia. There's acne clinics in some areas, which or they might be mixed into your general clinics. There is phototherapy, which I know a few photodermatologists who do a bit of medical dermatology as well. There's the biologic side of things, and that's where there's a lot of research going on. They tend to be a lot of more academic ones, though everybody tends to be academic, I should say. And then there's patch testing. Those are the ones that I'm aware of, and they're the ones you have to kind of get your box ticked for different placements within dermatology training. Oh, and I should say pediatrics, of course.
Yes. And you did hint before that, and it's kind of a medical meme or an in-joke or whatever, that you sort of hear this, call the emergency dermatologist or something like that, sort of this. People make jokes about this often, right? And I think we know deep down that it's not the reality, but it probably is quite interesting food for thought. What are some of the dermatological emergencies?
So there are dermatology emergencies. I mean, I guess it is all relative. There's not many which should get a dermatologist up in the middle of the night and coming into hospital. Saying that, I was on call Christmas Day and I had to go in for a dermatology emergency. So they happen, absolutely. And if you think about it, we've got a huge patients cohort that we look after. So there's some of them are going to have emergencies. Yeah, everyone's got skin, exactly. So the big areas are erythroderma, and then the severe cutaneous adverse reactions, so scars. Okay, there's erythroderma, which is essentially when you go 70% or more red. Okay, because your skin fails. So skin failure, essentially. I teach my students about this by using it as a reminder of what the function of the skin is.
Sure.
So your skin is there to, aside from just keeping everything in, really, it is there to regulate your temperature, to protect you from infections, and to keep you hydrated, prevent dehydration. Well, all of that goes to pot in erythroderma and some of these drug reactions. So therefore, the management of all of this isn't necessarily to anything particularly clever from a dermatologist. It is do your sepsis type bundle for infections and cover them for antibiotics. It is to keep them hydrated, sometimes requiring ITU admission, and it's to regulate their temperature. Stick a fan on, or put them in a bear hugger if they're freezing. And then you try to understand what the cause of that is. So with erythroderma, their causes are you can have psoriasis, so the kind of end stage of severe psoriasis, or same for eczema. And you can usually tell the history because they don't just come out of nowhere with this. They've got a history of eczema or history of psoriasis. Then there are some weird cancers and things that can cause it, which we sometimes will do like a skin biopsy to find out if that's the cause. Then there are drug reactions. So Stevens-Johnson syndrome and toxic epidermal necrolysis. They are the same condition essentially, but just different ends of the spectrum. Essentially, your skin falls off as a reaction to a drug. And it's like proper medicine. You have to go through everything and find out, look at their drugs and find out what's caused it. It's usually a drug reaction. Rarely it can be a virus as well. But essentially, you put the patient in a spacesuit and find out what the drug is, stop it, protect them from all the things I just mentioned, and then wait for the skin to grow back.
Yeah, if you want a bit of shock factor in your lives, guys, those of you watching, you've never seen a picture of what Stevens-Johnson syndrome or toxic epidermal necrolysis. It is a what Jonny said, how he characterized it, is like all your skin just falls off. That is a very apt description. It looks exactly as you would imagine it sounds. Something that we haven't addressed so far, and these are my painful attempts at segues as we go, but I've not actually asked you what specifically drew you to dermatology. You talked about the independence you had on your placement, but what was it that sparked it for you?
I saw a patient. I'll try my best for this not to be identifiable, of course. The first patient I saw when I was let loose was an elderly gentleman who had a rash on both arms, a cut off here, both arms. And he was there with his 2 daughters. And it turns out this gentleman had a history of cognitive impairment. And I just sat and talked to him and did a bit of a history. And it turns out what had happened was he'd been recently banned from his allotment because of his cognitive impairment. And he was sneaking out in the middle of the night to go to his allotment, and he'd found these latex gloves, and they were causing a contact dermatitis.
Oh, right.
And that's what caused it. And so I thought, I worked that out without knowing any dermatology at all. That's just detective work. And I was like, that's proper medicine, that, because we were able to fix that. So that's what kind of sparked my interest in it. I like looking at things and saying that's what that is, because that's always cool. I like being the person that people come to when they don't know what the hell's going on.
Yeah.
That's it's a bit of a bit of humble brag, but I quite like it. It's a nice buzz. That's why people do most specialties, to be honest. I like weird stuff, which is good. But I think what I really discovered, aside from just the variety, what I mentioned earlier, because you do learn something new every day, and all that lifelong learning stuff isn't just kind of pulled out of nowhere. That's really important. But what I really like is that you can actually fix people.
Yeah.
So throughout my
yeah, sorry, it's in most of it's in the black fridge. Okay. Yeah. Sorry.
It's all right, I'll start that again. So what I really like is that you can actually fix people. So when I as I mentioned before, I did a lot of stuff before dermatology, and the guys watching this who are medics or who qualified medics or have seen a lot of stuff in hospital might empathize. But we do a lot of medicine that doesn't involve curing people and has people coming in and out and in and out and in and out of the same problems, and you just don't feel like you've really you don't feel like you've managed them fully, and B, you might feel like just like one cog in a massive machine where you're doing the discharge letter, doing the bloods, or following the consultant around and pulling the curtain. But in dermatology, we genuinely can fix people.
Yeah.
So I can give 2 examples of that. One is Roaccutane for acne.
Yep.
Roaccutane is a very emotive drug because there's a lot of issues with it in terms of mood and things, but which isn't really all that proven, but there's stuff in the media. But essentially, Roaccutane is a tablet we give for acne, and it essentially cures acne, okay, or as close to curing acne as we get. Every single patient I put on acne, so I put on Roaccutane, their acne will clear, and that's life-changing for these patients. They come and tell me that I have changed their life, which I've never had in any other specialty. That's not just because I'm rubbish at other specialties, but most people don't tell doctors, junior doctors, that they've changed, that you've changed their life. Okay, and the vast majority of patients don't need any more isotretinoin or Roaccutane ever again, and that's them cured and fixed, which is amazing. And then for biologics, for psoriasis, for example, I give people a couple of injections a year, and their psoriasis, which was previously caked over their skin, they were between bars to go swimming with their child, and now it's gone while they're on that drug. That's 2 injections a year, which is just amazing, and so there's a real satisfaction about making a difference. All this cheesy stuff we talk about in our interviews for getting into medical school about making a difference, you kind of get that beaten down away from you whenever you're as a foundation doctor, because you just want to get through the jobs, take off all the stuff on your list. You kind of rediscover that as a registrar, and there's no better place to do it than dermatology.
That's really encouraging. Really nice to hear, especially something so personal, as you say. And then I guess, again, probably the most common question I got asked, and I know you have some strong feelings on this, so it might be the time to talk about them, which is that someone who is an aspiring dermatologist at any stage of their career frequently is medical school now. What are the sorts of things that they can be doing or they should be trying to see in order to hopefully one day get that training number?
Okay, so I'm asked this a lot, and I have given a few talks on this, and I would say that, first of all, be sure you want to do dermatology, okay? Because it's a difficult road, it's a competitive road, and you will get knocked back a few times, okay, at different stages. So be sure you want to do it, and to do that, go to clinics, shadow, email consultants, say, can I go to your clinic? They're never going to say no, really, unless there's scheduling issues, but generally you'll get in. Do an audit or QIP in dermatology at medical school. Most medical schools ask you to do that at some point anyway, so do a dermatology one. Read about research, perhaps get involved in research if you can, but you do not, and I repeat, you do not need a first author original research paper in dermatology at medical school, okay? I didn't get one of those until I was a core medical trainee year 2, which was months before my interview. And my paper was on an escape room in dermatology.
I remember. Yeah, I've read this paper.
so like I that counted. So I don't think the email I get most from, or Twitter message I get most from students in this situation is, can you help me get a paper published? And it's not really about that. It's not about me or other mentors giving you research to do, because you don't necessarily always learn something from that. Research is difficult. Research takes time. Good quality research should take time. It should be difficult.
Yeah.
And you should learn something from the process. And you want to do something that you're passionate about, something you're genuinely interested about, and that's going to keep you going or keep you driven in, look, when you're sat writing up your 3rd draft at 2 a.m., having been rejected from 2 other journals, or having struggled to get ethics. So therefore getting some experience in dermatology and understanding what you're interested in is important there. I would also say, don't be hard on yourself and take your time. Don't burn out, because like I said, it's a long process. You do have a lot of time. Play smart, not hard necessarily. Okay, so you don't, for points wise, they don't all need to be in dermatology. Okay, so QIPs and audits and stuff, you have to do one in your core training anyway. So don't fret about those. Okay, if you can do one in dermatology, fab, do it. If you can't, fine. You'll get your exams, because you have to get your exams basically. Prizes wise, there are a lot of prizes out there. There's British Association of Dermatology website has got a lot of undergraduate prizes we can look at. But again, doesn't have to be dermatology specific. So look at, so I'm a director of ASME, the Association for the Study of Medical Education. We've got loads of undergraduate prizes there. There is a Royal Society of Medicine has got lots of undergraduate prizes. And the thing with these prizes is no one submits for them, because everyone thinks, well, I couldn't get that. There'll be people far better than me at that. And therefore, no one submits for them. I've marked some absolute rubbish for some of these prizes, and they've won because no one else does it. Okay, so back yourself. Then I've already talked about publications, presentations, and posters at conferences. Just submit stuff, because again, conferences want your stuff, because that means that you're going to come to their conference. You're going to pay to come to their conference. That's another attendee. Therefore, they're incentivized generally to take you. Okay, if it's a very competitive conference and you're submitting something that's maybe not so good, then fine. But there are a lot of student conferences. There are a lot of trainee conferences. We just had one at TASME. But then, shoot for the stars. When my biggest conference I presented at was in Stanford, California, Medicine X Education, which was class. I loved it. But I basically submitted 4 things to it, thinking if I throw enough shit at the wall, some of it will stick. And now you're gonna have to do a content warning. Sorry.
It's like 46 minutes in or something.
It's fine. It's fine. Yeah. Some of it will stick, and then all of it was accepted. And I thought, oh no, I'm going to have to make 2 posters and 2 presentations. Things will get accepted, so just go for it. Back yourself. So that's what I say. General tips: back yourself, go easy on yourself as well, and take your time. And then finally, sorry, I will also say reach out for mentorship, because there's loads of people on Twitter, loads of people on Instagram who will want to help you, and are happy to help you. It just takes it just takes a bit of motivation, and you have to lead that, because it can be a bit hard for the mentor to hold your hand throughout.
Yeah, that is something, as maybe a note to finish on. Even at my stage, I get people asking, obviously, for help, who are maybe in their early preclinical years of med school or thinking about coming. And it's, if you don't come with specific questions or specific things that you would like to achieve, or the ways in which you would like to achieve them, it's really hard to effectively mentor, because you end up having to explain like everything.
Yeah. And I don't mind explaining everything if that's what the purpose of it is. If your question is, that's why I want to do dermatology, that's fine. Sorry, I just got a phone call just a second. I don't think I'm on call, but sorry. Hello. Oh, hello. I'm just doing an interview. Can I call you back? Okay. All right. Okay. Bye. Sorry, it's my girlfriend. It's just she rang from a hospital phone, so I thought it was sort of I would have ignored it otherwise. Honestly, sorry. So I don't mind being called. So I don't mind explaining everything, if that's the purpose of the question, and to give experience and talk about experience. But if you are coming in with just to get the points, people know. So I usually follow up the initial message with okay, what are you interested in? That you have to, the spiel I just gave about you have to be passionate about this, and I have about a 50% filter rate. People don't come back a lot of the time, which is unusual when you're offering mentorship. And then the other thing I would say is, if you are a first year medical student, just for the one example you mentioned, go out and enjoy yourself, please. You're not going to get these years back. I know I sound ancient. I'm not much older than 30, but it's the best time of your life. Enjoy yourself. You've got so much time. Just because other people look like they're doing a lot of research doesn't mean they're doing it. Just because other people have got a couple of points doesn't mean anything at medical school stage, really. No. So don't put that pressure on yourself. Just chill out for a bit. In fact, when I get messages from first year students, which happens, I tend to say no, and I see it as a little bit of a red flag at times.
Well, what a place to end. Some good life advice. If it's keeping things realistic, isn't it? And making the most of the time you have, because as you say, you're not going to get it back. So make the most. So thank you so much, Dr. Jonny Guckian, Dermatology Registrar Extraordinaire, for your time.
No problem at all. It was a pleasure as always, Ollie.
And all of Jonny's details will be on the screen. The ones that he provides will be on the overlay for the video.
Hopefully not all of my details.
Not all of his personal, like credit card number, sort code, and so on. But I'm sure you won't mind people reaching out.
Yeah, it's fine. Absolutely. Always happy to offer support.
And go give him a follow on all the platforms as well, because Jonny has a really interesting academic mind, and a lot of the things that you share on Twitter especially are really good. They often spark a bit of debate or food for thought. They are but important things to be aware of for med students. So please do go and give them a follow. Thank you so much for watching, guys, and take care of yourselves. All right, bye, Jonny. Thank you.